Good evening, everyone. I'm Neil Love from Research to Practice, and welcome to this special keynote session leading into our 4th annual National General Medical Oncology Summit that we've been doing for the last few years in partnership with the Florida Cancer Specialists. Tonight, we're going to be talking about ER-positive metastatic disease. Tomorrow morning, we'll have the same crew back to start off here. Our speakers coming into Miami this weekend deal with a whole bunch of other tumors. We're starting out here with breast cancer. We'll continue tomorrow morning, again, finishing out breast cancer and then moving on. First of all, I'd like to introduce our faculty here tonight from the far side. Dr. Jinja Borges, Dr. Hal Burstein, Dr. Joyce O'Shaughnessy, and Dr. Aditya Bardia. And before we start getting into the nitty-gritty of what we intended to talk about, I wanted to just show you, Joyce, this is a curve I was telling you about in prostate cancer. The oncologists here who treat prostate cancer, you're very familiar. This is the EMBARK study that looked at the very controversial issue of treating PSA relapse. So men who had primary prostate cancer and then developed a rising PSA, which of course is a great biomarker, but a molecular marker nonetheless. And Matt Smith, who's actually going to be here this week, and coined the term pelican graph, because you can see how wide the disparity was in treating these patients and really seeing a huge benefit in really treating molecular disease. And Joyce, I thought a little bit about all the trials that have been going on in the last few years in the PSA space when I saw this press release just the last couple of days. Seems like every week we're seeing press releases about new data sets that are coming out. And this one, very, very interesting. The SERENA-6 trial, looking at a yet unapproved oral SERD, selective estrogen receptor degrader, camizestrant, being introduced in the first-line metastatic setting at a point at which patients are not clinically progressing, but have developed an ESR1 mutation. And Joyce, the press release, as is always the case, there's no specific numbers. I couldn't get anything out of the faculty ahead of time. I don't know whether they know the numbers or not. I don't think so. But of course, we'll be very interested to see that. But I just wanted to bring this up to start this whole conference because I'm wondering if this is really going to change practice. Of course, Joyce, we need to see the data. I don't know, maybe we'll see it at ASCO. But any preliminary thoughts, Joyce? What are you going to be looking for? And do you think this is going to change practice so that this is the way we're going to manage metastatic disease?
Yeah, I've thought a lot about this in advance of this because, unless we have survival, we don't want to change early, but I actually don't think at the end of the day, from a practical standpoint, I'm going to put my nickel down that I predict this will change practice. And just as it's for people that are on their AI and CDK, and they're being monitored for ESR1. If you find an ESR1, you leave them on their CDK and you switch them from their AI to camizestrant, an oral SERD, to go after that ESR1 mutation. And it's got a PFS advantage. We don't know how much. But the thing is that if they stayed on their AI and CDK and you weren't looking for ESR1, why don't you just give them imlunestrant and abemaciclib second line? That's the question, is do you have to do them all? Do you have to change up front, or can you just wait till they progress and then give them, a different CDK with an oral SERD? And I don't know that we'll ever know the answer to that, but I just say if I'm a patient, I'd rather know if I'm developing an ESR1 mutation and knock it down and get off of my AI, which is basically the selective pressure to make that ESR1 mutation come out. So I just want to prolong that first line, even though it may be 1.5 line now or something. I just want to stay on my CDK. I want to stay on endocrine therapy, and I want to be progression-free for clinically progression-free for as long as I can. So, the issue always comes down to cost. But even if we don't see survival, which I don't think we will, because there's so many subsequent therapies to come, I still think that the molecular age is here, and we're going to be monitoring for these things.
I love it when new data sets come out and I get a chance to sit down with a faculty like this and pick their brains. We actually did 3 CME programs at the San Antonio meeting, and right in the middle of that was the EMBER-3 study that we're going to talk about today. And I watched that presentation. I'm like, what are they going to do? But then I got 10 opinions, just by talking to the faculty. We'll get into that later. When we were talking before, Ginger, you brought up a patient you saw that actually you thought a lot about based on this press release.
Yeah, it was just coincidental that I have a young woman in my clinic who I've been treating for de novo metastatic breast cancer, and initially it looked like she was responding quite well, and so a case like that, you would expect she would be able to be on her AI and CDK4/6 inhibitor for a long time, like at least, many months to a year. But here we are now, just a couple of more scans down the line, and there were these mixed results that made me nervous. So not even knowing that SERENA-6 was going to have a press release, I just, asked her, would she mind if we went and got a ctDNA? And sure enough, she does have an emergent ESR1 mutation. What triggered me to do this was the fact that I saw something mixed on her scan. So it's not exactly this Serena scenario, but I am going to switch her therapy because in this case, I think she's got a bad acting breast cancer, and the ctDNA test let me find that. I think with the Serena-6, as Joyce mentioned, the devil will be in the details when we see the data, but stability wins the race in the long-term haul of breast cancer survival in the metastatic setting. And if the detection of the emergence of the ESR1 mutation truly gives us a lead time prior to what radiologic progression would be, and intervening then gets us more time in the second-line regimen, it will be worth doing. If the emergence of the ESR1 mutation molecularly does not correlate necessarily with timing to when the radiologic progression would happen in a meaningful way, and we don't get any added benefit, then we're just leaping off of therapy before we need to. And I think that's why we need to see the data and figure out how we're going to interpret it and what to do about it. Our patients can live for many, many years, some of them decades, and we don't want to give up on good drugs without being very certain that's the right thing to do.
So Hal, curious about your thoughts. And also we're seeing, cell-free DNA, MRD assays starting to go throughout, start with the colon cancer, and people are doing it in breast, even though I know it's kind of like not accepted, et cetera. But any thoughts about, this strategy of, attacking the disease earlier using molecular markers, or are we just, really in the long run not going to make a difference? Any thoughts?
Well, I think if we see a pelican curve here, then you're really onto something, and it's very important. I think if we see that you've squeaked out a little more time, that's not so dramatic. You remember they started with 3,000 patients that they screened here. This is first line, largely de novo AI plus a CDK4/6. That is not the population we typically see in the United States, where almost all the patients who recur will have previously had an aromatase inhibitor, because that's what we give to higher risk ER-positive breast cancer. And so they had only 10% of those patients who they could identify an ESR1 mutation. And so you're doing an awful lot of serial testing to identify a small fraction of patients. And as in Ginger's case, many of them will have had actual clinical progression at the same moment as you begin to look for that. So it'll be very interesting to see. I think it's a very interesting approach. And as you alluded to, there's a lot of interest in looking for molecular evidence of recurrence. I wish we had drugs that were as powerful as we see in CML or in prostate cancer, where you can find a molecular recurrence and then, do something about it with such effect.
Aditi, any thoughts also? Any thoughts about cell-free DNA and MRD in breast cancer, and whether that may end up being an important biomarker even in the adjuvant setting?
It could be. I think regarding this study, I agree with what's been said previously, and I think overall survival does become an important endpoint, and if it's not addressed by this study, we might need another study. Dr. Borges had previously mentioned SONIA 2.0, which I think would be an important study, with being that you switch at the time of ctDNA rise versus regular switch. So early switch versus regular switch, does that improve outcomes? Because the arm that's missing here is camizestrant plus CDK4/6 at the time of regular progression. So people who are in the control arm, if they get that drug and that has equivalent outcomes, then do you really gain much by early switch? I think we need a study. In the MRD setting, it's slightly different, because there we're talking about cure. And even if there's a small number of patients who are cured by early therapeutic interception, that would be very valuable.
That's a great point. So here are the 4 modules and the 4 talks so that you'll see, and after each talk, we're going to hear about some actual cases from the faculty and also questions that we've been getting along the way. So we'll start out with Dr. Borges. talking about CDK4/6 inhibitors in the metastatic setting.
Thank you so much, Neil, and happy evening, everybody. On paper, I'm Dr. Virginia Borges. I do go by Ginger in person, and always happy to be called that. These are my disclosures. And for our agenda tonight, we're going to talk about the pivotal CDK4/6 inhibitor trials, decide how first-line therapy options can be made, talk about some toxicities and management strategies, and then sequencing as treatment options based on some of the relevant data we've seen in the last couple of years. So first-line therapy decision-making, where are we in 2025? Is there still a role for frontline chemo? What is the best endocrine therapy choices, monotherapy, or should we always be giving it in combination with CDK4/6 inhibitors? I made this timeline for something actually Dr. Burstein invited me to write a few years ago, and I modified it for this. And just to remind everyone, tamoxifan's been around since the 70s, and there was a long gap before we then had the AIs and fulvestrant as the first SERD. And then there was another long gap until all of a sudden we've had an explosion of new drugs entering the field in combination and single agent in the hormone receptor-positive metastatic breast cancer space. And there's that intentionally left blank little line there in the 2025 space for all the things that might come yet this year based on studies you're going to hear about tonight. So in the past, one of the things about the algorithm we always had built in was this arrow off to the side that said if at any time there was an organ crisis present or impending, we were still reaching for combination chemotherapy, and we'll talk about that tonight. And there was still always some lip service given to the idea that even after all the CDK4/6 inhibitor studies came out, we could still offer single-agent endocrine therapy in quote-unquote select patients. And that's also what we're going to talk about tonight. Of course, I take care of a lot of young women, so I always like to remind folks when they go from early stage disease to then metastatic progression, if they've been off of their endocrine treatment, don't forget to suppress their ovaries, make sure they have adequate contraception, which ovarian function suppression is not. And if they've not had their bone supportive medication, get that going as well if they have bone meds. So these are the studies that we had in the various settings of metastatic breast cancer with the 3 CDK4/6 inhibitors that have been approved in the United States for a while. And in all of these studies that were randomized, the combination therapy showed better progression-free survival than the monotherapy. And we waited for many of these studies to then give us survival data. We now have big updates from this, and the light blue part of this slide really just tells you the details of the study. So focusing down below on the dark blue part, we have the 4 studies that were in combination with an AI or tamoxifen, and the 3 in combination with fulvestrant. And you see that in the comparison of the median overall survival and the hazard ratios reported, there was benefit to the combination therapy across the board in these studies. In some of the studies, the hazard ratio did cross the line of 1, saying that it was not statistically significant, but it is clinically meaningful benefit for all 3 of the CDK4/6 inhibitors in all of these trials in terms of the fact that it benefited both in progression-free survival and overall survival. And there's starting to be lots of meta-analyses out there and real-world data coming forth looking at that as well that you could delve into. One of the ways we can distinguish our choice for our patients is not looking at the details of differences in overall survival, but looking at the details in differences of toxicity, because they are 3 different drugs. There are multiple CDKs. There's 4, there's 6, and there's 9. And depending on how a drug selectively affects them is whether it will be more likely to cause hematologic toxicity, such as in the palbociclib, or more likely to cause GI toxicity, such as in the abemaciclib, which is driven by the CDK9. And the ones that I have boxes around are the ones that are clinically significant. And yes, I did pick hair thinning. Our patients don't like to have their hair thin, and there is a slight difference there. But the biggies are, of course, the neutropenia and the grade 3 and even grade 2 and grade 1 levels of diarrhea, nausea, and vomiting. One of the things to keep in mind is that we can actually see pneumonitis with the CDK4/6 inhibitors. In this case, it was mostly an abemaciclib in this pharmacy review, but we can see it with all of them, ribo and abema higher than palbociclib in this case. And there are also many meta-analyses looking at this as well. But these are the basics of how you could choose. So if a patient has bad issues already with their GI tract, you might not choose abemaciclib. Conversely, if they've always had problems with their counts or tend to run low, perhaps you would avoid the palbociclib or the ribociclib. We could also turn towards some prognostic subgroups, and here's an update that we got from Monarch 3, including Dr. O'Shaughnessy being on this paper. And what it showed us is that there are different subsets who tend to look like they get more benefit out of being on the CDK and AI as opposed to just the AI. Specifically here, I'll draw your attention to the fact that the progesterone receptor negative, the high tumor grade, the shorter tumor-free interval were the main drivers. In the bone only and the liver mets, there just weren't that many cases in the yes and yes of those two subgroups. So it could be a number issue why we didn't see a bigger difference there, because we do see bigger differences elsewhere. So let's talk about some sequencing. There's been quite a few trials, but for tonight I'm going to highlight these three, which I think offer the opportunity for practice-changing results: SONIA, Right Choice, and Post-Monarch. So this is the SONIA trial, and this was presented recently and now published in Nature. And this was the primary outcome analysis of selecting the optimal position of the CDK4/6 inhibitor in our hormone receptor-positive MBC. And so the schema is there, and you can see that these were both pre- and postmenopausal women, and they did not have any prior therapy in the metastatic setting, and none of them were in visceral crisis. It was a 1,000-patient study. They were randomized to either starting up front with a nonsteroidal AI plus the CDK4 or a nonsteroidal, and then they were switched over to either fulvestrant or fulvestrant with the CDK4/6. And here you can see the primary endpoint of overall survival from the CDK first versus the CDK second shows no difference. And when we look at the forest plot in terms of who would benefit from CDK first better or as a second-line therapy, most of all of those arms cross the line of one. There's a couple of differences, if you notice, in the pre- or perimenopausal women, really trending towards the first-line CDK being better, as well as the PI3K mutation status. This was an interesting analysis out of this study looking at the financial toxicity of the CDK first versus second group, with an average cost of $184,000+ per patient, knowing that the data shows us that patients can be spared about 15.6 months on a CDK4/6 inhibitor in the front line without loss of long-term benefit and survival, and for a significant cost savings. I was interested in what they listed as the costs of the drugs, and the differences seen there. I didn't realize there were such differences between those three. Next is the Right Choice study, where ribociclib plus endocrine therapy was compared to combination chemotherapy in premenopausal women with clinically aggressive hormone receptor cancer. And so there's the consort diagram there showing how the patients came onto the study and how they were assigned. And here are the mean characteristics of the patients randomized between the two groups. And what I want to draw your attention to is what they mean by aggressive hormone receptor disease. So half of these patients were in visceral crisis. Most of them had visceral disease, including over half with more than 3 sites. And what we see in the results is that the ribociclib with endocrine therapy arm actually outperformed combination chemo. And in this case, the combination chemo was either docetaxel with capecitabine, cape with gem, or cape with navalbine. And so, we don't use a lot of combination chemotherapy in MBC, but in this case, the ribociclib outperformed with no loss of survival benefit. When we look at some of the pre-specified aspects of who might derive more benefit than others, what we can see is that the presence of liver metastasis still favored ribociclib. Visceral crisis, it did not matter in terms of which they received. Chemotherapy looked a little better, but not superior in that regard. De novo disease obviously did very well with the endocrine combination. And I highlight the time to response curve there and intentionally draw a circle showing that there's a very fast takeoff in response in either arm. And so really, if you get people to respond quickly, even if it's not necessarily as dramatic within the first 3 months, but you get enough of a response, you can get them out of visceral crisis, and this endocrine therapy combination did that. So I think this highlights for us that the algorithm has changed. We can very confidently offer our patients single-agent endocrine treatment if they are appropriate as such, and we do not have to consider the combination chemotherapy any longer. We can feel comfortable about the CDK4/6 plus AI, even if organ crisis is present. So I think we are moving away even further from giving chemotherapy in the front line for our hormone receptor-positive patients. And of course, if they are endocrine resistant, we want them on a SERD plus a CDK4/6. And my colleagues here tonight will talk to you about the ANOVA data and PI3 kinase, so I won't highlight that now. So what about after CDK4/6 inhibition? We have the data from post-MONARCH, which looked at abemaciclib plus fulvestrant after progression on a CDK4/6 inhibitor. And this is who was included in the study, again highlighting a lot of patients with visceral disease, a few de novo at diagnosis. They all had prior CDK4/6 inhibition, the most of which was in the advanced breast cancer setting. And their duration of how long they had been on the CDK4/6, there was about a quarter of them who had been on it for less than 12 months. And what we see here is that across all of the clinically relevant subgroups, there was benefit to being on the abemaciclib plus fulvestrant. A and B are those who were with and without visceral crisis, and G and H are those who were under 12 months or more than 12 months on their prior CDK4/6 regimen. And as you see in the forest plot, all groups showed benefit to this combination with abemaciclib, telling us that we can now sequence in the CDK4/6 space and get good data. So it's starting to get to be a very complicated graph in the second-line therapy space, something sort of looking like this. But we have a lot of options, but we can still extend the use of the CDK4/6 inhibitors for appropriately selected patients. So that's it.
Awesome. So actually, the first question we got in here, I'm going to save for tomorrow. It's a patina question, but that was the trial that showed CDK being positive and HER2 positive patients. It's just presented at San Antonio. We're talking about HER2 positive tomorrow, but interesting, starting to think about Serena-6 in a patient with HER2 positive disease. Really interesting. But I want to get into the cases. Before we do, I want to just show you, we have our way in research to practice to do consensuses. You have the guidelines out there that, and ASCO recommendations, et cetera, that look at the evidence. What we like to do is just ask the experts, like, what do you do, and see if there's a pattern there. And we just had 3 posters at the San Antonio meeting, and one of them looked at this question of first line that Ginger just discussed. I thought you'd be interested to see what some of your colleagues, I think a lot of you were actually in this initial survey. So I'll start with you, Hal. I was just flashing Hal when Ginger was showing the graphics of the CDK side by side. I remember early on in CDK history, you would put up these slides comparing, saying, I know I'm not supposed to do this, but then you would put the slide up and say, wow, they really look very similar. Of course, that's before Ribo started to move ahead of the pack. And then Hal did the discussion of the EMBER-3 study that we're going to talk about later at San Antonio. And again, he put up a trial comparing the prior oral SERDs and EMBER-3 and said, I know I'm not supposed to do it, but this one actually looks better. But anyhow, Hal, in terms of this, very common treatment decision that seems to be swaying the way we saw it when we asked, 20 breast cancer investigators like yourselves, what's their typical first-line therapy in a patient with ER-positive disease? Most of them said Ribo, a few said Palbo and Abema. And we picked out a case that we're going to show in a second, because I heard you were kind of a Palbo person, so I thought I'd start with you and see what your thoughts were. I'm going to ask Joyce also. Here's another question. We said, Ginger was showing the data with Abema and liver mets. We said, well, suppose the patient had symptomatic visceral disease, still a little bit more now with Abema, but still mainly Ribo. And Hal, you're I guess down there with Palbo. What are your thoughts?
Well, first of all, I'm not sure I'd trust 20-odd breast cancer oncologists to answer anything, much less which drug to use. Look, this is an important class of drugs. They have become the mainstay of our first-line treatment. Collectively, they shift the survival experience for women with ER-positive metastatic disease. They also, even perhaps more critically, shift the time until the initiation of intravenous chemotherapy. They maintain quality of life. This is a very important class of drugs. Personally, I don't think it actually matters all that much which drug you give. To Ginger's presentation, I think there's a lot of similarity. There was some data looking at the Flatiron registry experience at ASCO, at San Antonio, and the outcomes in the United States based on healthcare records look pretty much overlapping for which drug you use. Abemaciclib, I actually sort of like to hold for the second line based on the post-Monarch experience that Ginger alluded to. I don't really have a horse in whether you choose Palbo versus Ribo, but I have found Palbo to be very well tolerated. And if you look at some of the newer data that I'll speak to in a moment, combining a CDK4/6 with inavolisib, it was Palbo because it's very tolerable. In the Patina study you alluded to, where they're getting trastuzumab and pertuzumab, it's also Palbo because, again, it's very well tolerated. And to be fair, I mean, this is it's going to be a big economic issue because palbociclib will become generic in 2026 or thereabouts, while the others are still on brand drugs, and so the price will drop. 90% or so is expected for Palbo compared to the others, and I think that while we never want to compromise on what's best for our patients, that would be an opportunity to reflect on whether we're spending money as wisely as we could be.
So Joyce, I always loved how you think through cases so deeply, and curious what your thoughts are, particularly this scenario of a patient with a visceral Mets also. We said in the unusual situation where the patient had brain Mets, people did prefer Abema, which of course has been seen CNS activity. Then we presented a 85-year-old woman with multiple comorbidities, and you see there are a variety of opinions there. Joyce, any thoughts? And any thoughts about the preference for Ribo that in general we're seeing both in investigators and in community-based oncologists?
Yeah, I think that because the 3 first-line trials with Ribo show a survival advantage, it's got the strongest data in the first-line setting for survival, and that's mainly what I do recommend. I do use the Palbo for the frailer person, polypharmacy.
You're discriminating against the frail people.
and people that are don't want to make the treatment worse than the disease. That I do use Palbo, no question. But where I use Abema as well, first line, for endocrine therapy resistant disease. If I feel like there's no way this cancer is going to respond to single agent endocrine therapy, then I will use abemaciclib for a number of reasons. It's got a broader spectrum of activity, no question about it. It can probably get CDK2 in addition to CDK9. You're not stopping it. You're not stopping for a week, so you're going. So if you've got aggressive disease. Thirdly, both in Monarch 2 and 3, the subset analysis for the short treatment-free interval, Ginger showed the Monarch 3. It's the same in Monarch 2. Liver mets, short treatment-free interval, and grade 3, PR negative. I mean, it's really in favor of the abemaciclib. And lastly, my personal experience. I've had to switch gals. Starting at Ribo level 1 evidence, and I don't like this, so let me switch it over here, and I see benefit. It's usually aggressive disease, that really isn't really endocrine therapy sensitive.
Yeah, and actually your first case is an example of that. We'll get to that in a second. But Aditya, any thoughts? We're hearing more and more about this concept of endocrine resistance, both in the first line setting as well as beyond. It looks like that's an important, how long somebody's on a CDK inhibitor is a good predictor of how well they'll do on a SERD. Do you, any thoughts about Joyce's thought about maybe thinking more about Abema and somebody you think is endocrine resistant?
No, absolutely. You should remember that Abema also has single agent activity. Mm-hmm. It's the only CDK4/6 inhibitor that's approved as a single agent. So if I'm not that confident of my endocrine therapy partner, Abema is an agent that I would lean towards.
What's your experience in terms of tolerability with Abema, and are there situations where you avoid it or even encourage it?
So main toxicity with abema is diarrhea, and it's usually in the first couple of cycles. Couple of strategies to address that. One is the use of antidiarrheal, sometimes even primary prophylaxis in the first 2 cycles. The second is to use a lower dose, 100 BID, which is a good dose of abemaciclib, and if a patient is really doing well, you can then increase the dose later on.
All right, so let's get into some of these cases. We're not going to do an A to Z presentation. We're really going to just try to focus on one point. I will say that I want to talk about this case tomorrow as well, because tomorrow we're going to be talking about a localized disease. And just to point out in the history here, again, we'll talk more about it. We were talking about this in the faculty room too. This 36-year-old premenopausal woman elected to go with a positive approach of holding off on her adjuvant endocrine therapy, which was leuprolide and tamoxifen, and had a child nursed for a year. We'll talk about that tomorrow as well, and then developed, unfortunately, recurrence. So let's focus on the recurrence tomorrow. We'll talk a little bit more about the positive aspect. And Joyce, this seems like it's kind of like what you just said.
I know.
What happened?
Yeah, this woman, young woman, recurred with pleural-based disease only. And the biopsy was ER positive, HER2 negative, ER/PR positive. So I would have thought that was endocrine therapy sensitive disease, and so I put her on leuprolide, ribociclib, letrozole, the Mona Lisa 7 approach, but she's a germline check 2 mutation, and she just really didn't get a good response. She had like a stabilization of her markers, and they started to ever so slightly creep up. I'm like, no way, she needs her 2 years, and so I switched her over to abema and kept her endocrine therapy going, which was an AI, and then she had a great response. I mean, the markers came right on down, and she had 2 years. And so, and I've had that happen in about 10 patients or so. It tends to be the genomically unstable patients with either germline mutations or just very aggressive type disease, the kind again that's endocrine therapy resistant, although this gal I would have predicted was endocrine therapy sensitive, but it didn't work, and it might have been the check 2.
Interesting. So, Aditya, you came up with a few scenarios in a 55-year-old woman, and I think this is a very common situation, and you put out there what you think you would do with that. But can you kind of go through what this scenario is? I mean, basically, I guess this is a patient progressing on first-line CDK.
That's correct. Someone who was premenopausal initially got tamoxifen, and then at the time of disease recurrence became postmenopausal, and so received letrozole plus ribociclib in the first-line setting, which worked for a couple of years and then had disease progression, but it was just in the bone, and ctDNA analysis, which is what we do in the second-line setting, revealed no actionable alterations. So the question is what to do next. Fulvestrant without abemaciclib. I chose fulvestrant abema based on the post-monarch results, and it's a good combination. You're switching both the endocrine and CDK4/6 inhibitor. So that was my thinking in terms of why to use this regimen.
Ginger, you talked about the data, and I'm just kind of curious, what do you actually do in your practice? And does it matter what the first CDK is? Like if it's palbo, are you thinking more about post CDK abema than if it's ribo? This is scenario here that Aditi brought up was the patient got a ribo. Will you think about it with a patient who has ribo as well?
Yeah, so this would be very similar to my practice pattern. In the post-monarch, there was 8% of patients who had abema as their first-line CDK and stayed on the abema as their second. Now, it's hard to know what that contributed to in the overall results when it's only 8%. I think we are going to have to face this issue all the more as we start to see patients who have gotten CDK4/6 inhibitors in the adjuvant setting who don't necessarily recur early, but in the future, if they then recur later, how will we revisit their disease and what will we look at? So, but this would be essentially what I would do as well. I tend to use ribo up front because I take care of a lot of young women and had always leaned in on the Mona Lisa 7 data. Nothing against palbo.
And this would also be a scenario where we're going to talk about EMBER-3, the as yet unapproved oral SERD imlunestrant combined with abema was used in this situation as well. We'll see what the faculty thinks about that. So Hal, we were talking about the fact that the use of palbo, we hear of a lot of 80, 85, 90-year-old patients getting palbo. This is a 59-year-old woman. What led you to give her palbo?
She had metastatic ER-positive breast cancer, and I think it's a perfectly reasonable choice, and she did 3+ years or so on that, as I recall. So look, I don't, again, I think you have a lot of flexibility here in what you use. Truthfully, this patient probably would have been a good candidate for thinking about the SONIA trial, where you started with endocrine therapy alone, though she progressed on in AI, which made her a little different than some of the patients in that experience.
Any situations, Aditya, right now where you hold off on using a CDK inhibitor first line?
In general, I use CDK4/6 first line. A scenario where I would not use would be someone who is, say, elderly, 85-year-old, and I feel that they'll do well with single agent endocrine therapy, and I can always add CDK4/6 in the second line setting. Or someone who has a lot of comorbid conditions, and I worry that the CDK4/6 inhibitor would add to the insult in terms of the quality of life. But it's rare. Most patients that I treat, I give CDK4/6 inhibitor in the first line setting.
You call 85 old? Anyhow, I guess it's just a number supposedly. Incidentally, I was just thinking about the fact we're going to show more than 1,200 slides this weekend.
Oh, God.
So I'd challenge you to stay with me the entire week, and also you people up there too, the entire thing. I want you to hear all 40 people. But let's move on now. We're going to talk about another really exciting development. Amazing to think we could spend 2 hours talking about ER-positive metastatic disease, and we're barely going to get through it. So I don't think that was true 3 or 4 years ago. But Hal, let's talk about PTEN, PIK3, and AKT.
Great. Well, thanks for being here. And 85 is young in South Florida, so this is, this is the lower end of the spectrum here.
Young elder.
We don't want to malign your core audience. So, okay. So, increasingly what we're talking about is we know how to manipulate the estrogen receptor signaling pathway a little bit. We can suppress estrogen production with ovarian suppression or an AI. We can modify the estrogen receptor signaling with tamoxifen, or nowadays we can actually degrade the estrogen receptor with either fulvestrant or a variety of oral SERDs. And increasingly we are partnering those approaches with other pathways that feed into ER signaling, whether it's the PIK3CA pathway or the CDK4/6 pathway. And so almost everything you're talking about tonight is how do you best combine and sequence these various approaches where you're essentially picking one from column A and one from column B and trying to put them together. So there is another option that relates to this, which is an aromatase inhibitor with everolimus in ER-positive breast cancer. These data are over a decade old. 2 points to be made about this slide. The first is the drug was approved for an improvement in progression-free survival, and the FDA was so swayed by these data that not a single one of the next generation of the PIK3CA inhibitor studies has ever bothered to compare itself against everolimus, and the FDA was okay with that because everybody recognized it was a rather inactive and rather toxic drug. The second point is that in a lot of these reports, you're going to see local investigator report versus central assessment. You are the local investigator, so those are the outcomes that characterize what happens in your patients. There's an increasing recognition that so-called blinded independent central review makes the numbers look way better because patients who are censored for things you and I see in clinic, like a larger lymph node or more bone pain or a rising tumor marker, are not visible to the central radiology review. So one of the most important things to think about in this space is the actual frequency of the PIK3CA mutation in both the Bolero-2, which was one of the registrational studies for alpelisib, or in the tumor genome atlas data. Roughly 30 to 40% of tumors will have a PIK3CA mutation. In the ER-positive metastatic breast cancer space, it's the single most prevalent mutation that you will encounter on your Guardant 360 or Foundation liquid biopsy reports. If you actually look across the spectrum of breast cancers, focusing here on the far left column, roughly 25% of all have a PIK3CA mutation. It's about a third of ER positive. Actually, 25% of HER2 positive cancers will have such a mutation, and you'll also see it in triple negative breast cancers, but tonight we're mostly talking about ER positive disease. So alpelisib was the first successful use of an alpha-selective PIK3CA inhibitor to actually improve progression-free survival, a report that came out about 6 years ago, and it was generally enriched in the group of women who had a PIK3CA mutation. This particular study also included patients who did not harbor, or whose tumors did not harbor a PIK3CA mutation, and you can see in the bottom Kaplan-Meier curve there was really no benefit. Important just to remind you that unlike an ESR1 mutation, which is essentially an acquired mutation that goes along with a resistance to an AI, the PIK3CA or AKT1 mutations are present from the inception of the tumor, so you could theoretically test either primary or recurrent disease. So they've looked at a variety of different mutations, and it didn't really seem to matter which mutation you had. You still saw benefit with alpelisib. In the long-run follow-up of the SOLAR-1 study, there actually was no overall survival benefit, even though most of these patients did not receive crossover therapy. So one of the limitations of these drugs historically has been they really didn't move the needle in a substantial way on overall survival. So the newer data in this space is from the INAVO 120 study, and it's important to remember that this study differs in two ways. The first is this was a relatively resistant group of tumors. These patients had either progressed on or within a year of endocrine therapy in the adjuvant setting, and they had a PIK3CA mutation, and they were randomized to either a doublet of palbociclib with fulvestrant or palbociclib, fulvestrant, and a different PIK3CA inhibitor, inavolisib. And the study showed that there was an improvement in progression-free survival, shown here, and all the forest plot analyses favored, the broad group of subgroups that they analyzed. And intriguingly, there was an emerging signal of a survival benefit in this study using the PIK3CA inhibitor as a triplet, suggesting that maybe there's some magic in the interactions between PIK3CA inhibition and CDK4/6 inhibition, that when you double down on the non-estrogen part of that pathway analysis I showed you, you might really help people do substantially better. The response rate was actually quite high in the inavolisib arm as well, and I think that's notable, nearly a 60% response rate compared to about 25% in the group that got palbo plus fulvestrant. So where does that leave us? Well, we're not quite finished yet because there's one more potential target, the AKT target, in addition to PIK3CA and mTOR. And the AKT inhibitor, which is now commercially available, is capivasertib. So CAPI was studied in two important trials. The first was a randomized phase 2 study called FACTION, which compared fulvestrant with or without CAPI in a large cohort of patients, some of whom had a PIK3CA, PTEN, or AKT1 mutation, and many of whom did not. What you can see is that in the aggregate, there was a higher response rate for adding CAPI compared to fulvestrant alone. They actually did some beautiful genomic sequencing work here, and if you look in the red, they have now scored all these cancers as being mutated in the pathway, that is PIK3CA, PTEN, or AKT1. And when you break out the results of the randomized phase 2, that really cleanly discriminated who benefited and who did not. So in this analysis, if you look at the lower panels, what you're seeing, on the right side, what you're seeing is the tumors that were lacking a PIK3CA, AKT1, or PTEN mutation, no benefit for CAPI, all of the benefits seen in the group that harbored such mutations. So in the Capitello 291 study, they ran a phase 3 trial, again including cohorts that did or did not have one of those pathway-associated mutations. This was a larger phase 3 trial. And the results are here. So this was nearly a 700-person study. Roughly a third had a PIK3CA mutation. AKT1 mutations are relatively uncommon, 4 to 5%. PTEN mutations, again, actually it's PTEN altered, it's not specifically mutated, again, relatively uncommon at around 5%. Overall, there was a suggestion that CAPI benefited in progression-free survival on top. On the bottom, you're seeing the outcome in the AKT pathway altered tumors. That was the driver for the majority of the benefit. Subgroups across the board benefited in the forest plot analysis. There's a trend for overall survival, bordering on statistical significance in the AKT1 group, or signal pathway group. Again, here's the updated data for tumors with pathway mutations versus, on the right, those that do not. So again, the lion's share of the benefit here only in those pathway mutated tumors. So what else can we say about these drugs? The key thing to note here is that they do improve the response rate, and they also have side effects. So the most common side effects are mucositis, rash, diarrhea, and fatigue or asthenia. These are class effects of the drug. There's also a well-known side effect of hyperglycemia. And if you look at the incidence of grade 3 or 4 hyperglycemia, that is hyperglycemia that your nurse practitioner gets annoyed having to manage. That's the criteria for grade 3 hyperglycemia. You're not managing it. I know you're not doing it, but your nurse practitioner, your PA is managing it, and they don't want to hear about it either. But a third of the patients on alpelisib will have that, even despite very vigorous premedication and use of metformin, whereas with inavolisib and capivasertib, it's a lot less. And in my mind, that has made these latter two drugs much more appealing than using alpelisib in women whose tumors harbor these questions. So, as with the CDK4/6 inhibitors, we don't fundamentally know if one of them is truly better than another. There's never been a head-to-head study comparing any of these. I think what the data from the inavolisib trial pose as a very compelling question, unanswered at the moment, is it better to stack these drugs in a triplet or to use them sequentially across time? We do not know the answer to that question. And then there's a whole other wave of next-generation mutant-selective inhibitors. Some of these are more selective and in particular avoid some of the hyperglycemia that you see with these drugs. It's going to be very interesting to see how those move forward into the clinical space. So, with that, I even got it in on time.
Excellent.
Okay.
So getting some good questions from the audience. One interesting one is how you think about the tolerability of capivasertib versus alpelisib. We'll get into that in a second, which kind of leads into some more from our work asking people what they do. This is another poster we had at the San Antonio, or another poster we're doing looking at PIK3, AKT, and PTEN. First of all, in terms of first-line therapy, the triplet, we saw that this became standard of care as soon as it was presented and approved. And so when we present a patient who, in the first-line setting, has relapsed following adjuvant AI, it seemed like almost everybody was going with the triplet. Just curious, Aditya, is that your thought? And what have you seen in terms of tolerability with inavolisib?
Yeah, absolutely. I would go with the majority because we've seen improvement in PFS, and there was a press release that they've also seen improvement in overall survival with the triplet agents. So for a patient who has PIK3CA mutation recurrence on adjuvant AI, as per the clinical trial, I would use the triplet. The side effects I've seen include hyperglycemia, rash, not to the degree as seen with alpelisib, but one side effect that appears to be more than alpelisib is mucositis. It's manageable with the use of steroid mouthwash, very similar to everolimus, but it is a side effect to be aware of.
Interesting. We also said, well, suppose they have in the same situation, but not only they PIK3 positive, but ESR1 positive, and we still saw the same answers. And we'll get back to that in a second, but I also want to bring up the issue of second-line therapy in a patient who's been on CDK and an AI, and this question of which agent to choose, and particularly tolerability-wise. So Ginger, we saw, again, as soon as Capi became available, we asked investigators, what are you doing? And they go, we're using Capi and not alpelisib. Is that what you did? And how would you answer this question from the audience about the relative? Of course, you have a different schedule, too. I don't know if how much that ameliorates toxicity. Can you talk about, first of all, how patients respond to the a few days on, a few days off, and what you see, what you yourself use in a PIK3 mutant situation?
Yeah, I am surprised at how well my patients do with the on-off schedule, and I think the fact that it's sort of a 7-day increment, which we live our lives in 7-day increments, so that makes it easier than I even think when we went to regimens where it was 21 days on and 7 days off. We all live in 7-day increments, so I don't find that to be a barrier to success. Again, remembering that I do take care of a younger population, so they are managing their own meds and have all the devices and things that they can set timers on. Someone who takes care of more of the almost as young 85-year-olds might say differently. It has been a lot less phone calls from the nurse practitioners and the PAs in terms of managing the side effects, and so it's pretty easy to adopt it. I was an embracer of alpelisib, but I did have quite a few patients who had horrendous rashes and really could not stay on the medication, and we all know that patients can only benefit from a medication if they can take it.
Joyce, I'm curious how you think through these agents in terms of pre-existing diabetes. I've been thinking for a while it'd be great to do a hypertension 101 program for oncologists to update people on hypertension. I think it might be kind of cool to do a diabetology 101, so it's not just the nurse practitioners we're turning to in terms of diabetes management. Well, how do you look at this? And for example, you have a hemoglobin A1C level that you won't treat. Would you use a GLP-1 agonist to bring their hemoglobin A1C level down? Any thoughts?
Yeah, I learned with alpelisib that I could not cheat on the hemoglobin A1C at 6.4% or less. And if I cheated, they got into major hyperglycemia issues. So I learned that. With CAPI, it's up to 8% hemoglobin A1C. And so we've got more leeway there. And then now with inavolisib, it was up to 6%, but they're doing a trial to up to 6.4% with inavolisib. So, and using some upfront metformin, et cetera. So I think that if somebody is already just pushing up against the ceiling, then usually they're already on metformin and want to optimize that. I have added the SGLT2 inhibitors as my second line because they lower insulin levels, and preclinical work shows it's really quite effective anti-cancer wise. The GLP-1 receptor agonist is another interesting idea, but I probably would go with the SGLT2 inhibitor second. That's what I've done, but I really only needed to do that with alpelisib, not with capivasertib.
Hal, what have you seen in terms of tolerability with inavolisib? And I know it's being studied in the second line, I think, compared to alpelisib. What do you think that's going to show? And what's your own thought in terms of kind of toxicity you see?
Yeah, Joyce mentioned this at our pre-meeting. I hadn't realized there was an ongoing study comparing alpelisib versus inavolisib. And I think we need more studies like that. Since it's a Florida Cancer Specialist group here, there are lots of opportunities to do very practical head-to-head comparisons of these trials and of these drugs. And I think for community oncology practice, these are excellent opportunities, and I would like to see more of that. So far, it's reasonably well tolerated. You're still getting the palbo in there, and so you do see the myelosuppression and other things. But clearly, it's easier from a hyperglycemia point of view than the alpelisib is.
So, and Aditya, here, as I mentioned, we see that people for PIK3 are using CAPI, but we also said, what about AKT and PTEN? And of course, everybody's using CAPI in that situation. I'd like you to maybe respond to Ginger's case of a patient who actually got a triplet, although it was a clinical trial. Can you kind of just summarize how this patient got to the point of metastatic disease, Ginger? And then we'll talk about what happened at that point.
Yeah, so this is a young woman who presented, and she had not the worst looking tumor at baseline, 2.1 centimeters, node negative, grade 3. She was ERPR quite strongly positive, HER2 0, Ki67 was 30%, not uncommon in a 35-year-old. She did have a 21 gene assay sent, which gave a result of 28, and she elected to take adjuvant chemo with 4 cycles of TC, and she was on gaserelin for ovarian protection during that time. She continued on that and also took zoledronic acid every 6 months for 6 doses, and then unfortunately, she comes back in 2 years later. She has been compliant, and she had enlarging cervical lymph nodes. And so she got sent for some imaging, and it did show widespread metastatic disease, extensive lymphadenopathy, some bone mets. Biopsy proved it was the same tumor returned, similar markers. She had a genomic test performed, and her tumor is ESR1 wild type, BRCA wild type, and PI3 kinase mutated. So what should her first-line treatment be?
Aditya, is this a situation where you'd use that triplet?
Yeah, absolutely. I think this patient has PIK3CA mutation, and in this setting, Inavo with the use of palbociclib plus fulvestrant would be a very reasonable option.
So, and actually, I think she ended up going on a trial and got a drug that was a combination of you can refresh my memory.
She got palazestrant, also known as OP-1250, which is a Ceron, slightly different than a SERD perhaps, in combination with ribociclib on that clinical trial. Did very well on it for just over a year.
All right, and then Aditya, you came up with this scenario that It's very interesting. This is a situation where we don't see everybody giving the same answer. Situation, maybe you can talk a little bit about it, kind of going back on your base scenario, but now you've got a patient with both PIK3 and ESR1.
Yeah.
Can you talk about how you think through that scenario?
It's a similar situation as the last patient, but now rather than having no actionable alteration, this patient has two actionable alterations, which includes PIK3CA and ESR1. And from a genomic perspective, there are three options one could consider. One would be elacestrant, given the ESR1 mutation. The second would be fulvestrant plus alpelisib, and third, fulvestrant plus capi. In a patient who just has bone-only disease, I would lean towards elacestrant. The reason being that it's better tolerated. There's also data from the Emerald study that even if you have PIK3CA mutation, elacestrant does work as long as the patient was on prior CDK4/6 inhibitor for at least 12 months. And this patient was on prior CDK4/6 for 3 years. So it's still endocrine-sensitive disease relatively, and I would lean towards elacestrant. And if it works, great, good quality of life. And in the future, you can always consider doublet therapy after elacestrant.
Ginger, any thoughts about this? When we first started doing surveys, we just said, well, suppose they have both, and we didn't realize that people think about it much more, carefully, granularly about the case. How do you decide which way to go?
Yeah, I do think it's a case where the granularity matters. The fact that this patient had 3 years of benefit is probably the strongest indicator that you could get more mileage. Just targeting the endocrine. You have the choices that Aditya outlined. I would say in the setting of a PI3 kinase mutation, even despite that long benefit, I would be sure to watch this patient a little carefully, because we would worry that that might harbinger that they would not get as much benefit on single agent endocrine therapy, even with elacestrant. But there's no harm in giving them an attempt at it and seeing if it works well for them and getting as much mileage out of it before then you could reflex over to one of the PI3 kinase combos.
So before we get into Joyce's case, a quick question from the audience. How do you think about CDK patients who've had prior CDK in the adjuvant setting?
Great question, and presumably a looming, more frequent problem as we use more and more CDK4/6 inhibitors in the adjuvant setting. We really know very little about the outcomes of what those patients experience when they do have recurrence. We know very little about the molecular features of their tumor, and we don't know when a CDK4/6 inhibitor still might be active. So my guess is that in the real world, if they progress on a CDK4/6 inhibitor in the first couple years of adjuvant therapy, you're going to sort of move on, or if you really have the opportunity to think about a second-line CDK4/6, you might do it. If they are multiple years removed from it, you would probably reintroduce a CDK4/6 inhibitor. But this is, a healthy sign of progress, but it also invites a situation where we have hardly any data to guide our current management.
Another question from the audience for Aditya. We were talking before about endocrine resistance. This person wants to know, what about a patient who has a very poor response to CDK plus AI? We had a patient presented, I think, who progressed in 4 months. Do you abandon endocrine therapy at that point, or would you consider second-line endocrine therapy?
I would certainly abandon single-agent endocrine therapy if there are genomic alterations like PI3 kinase inhibitor or AKT mutation with PIK3C or AKT mutation. I would consider combination therapy. The other option in this scenario to consider would be a trastuzumab deruxtecan if a patient has HER2-low disease. In Destiny Breast 06, in that subset of patients who had rapid disease progression on first-line CDK4/6 inhibitor, you could see good outcomes with TDXT.
Yeah, actually, the person who asked the question says, what do you do after TDXT? Because they sort of assume that that would be what you'd use if they're HER2 low. Ginger, question, we were talking a lot about glucose intolerance with capi and alpelisib. Particularly with capi, what else do you see in terms of tolerability for practical purposes?
I've had good experience with it, so it's a pill. There certainly is the opportunity for some GI disruption, but I've been fortunate in that I really have not had a lot of patients need to come off of it due to side effects or toxicity. So I would say I've seen less than what has been reported in the clinical trial.
Do people feel differently when they're off the drug, or is their glucose different when they're off the drug?
It can be. So I have one patient who I felt very emboldened that day, and even though she had underlying type 2 diabetes, offered her CAPI because she was not going to do the alternatives. This was a patient-driven decision, not based on best evidence. But we did it, and I had very tight relationship with her endocrinologist, so she ends up dosing with IV insulin on the days that she's on it, and she does not need to take that on the days that she is off of it, as the most dramatic example that I could give you. I would not do that unless you have your patient's endocrinologist on speed dial, because they can get into very difficult trouble, but she wasn't giving me a lot of opportunities for what I could treat her with.
So, Joyce, like that, you have a patient here. Were you going to say something about this on-off thing?
Yeah, I think that diarrhea goes away when they're off the 3 days. They do feel better off of it, but the diarrhea is an issue, but not that bad, not that bad. And the other one, I've had to reduce the dose once or twice for fatigue, but it's a cumulative thing. But the patients generally feel well, but the 3 days off really kind of resets everything.
So you have another 36-year-old. If I go by you all, I think the average age of breast cancer would be 35, but out in the real world, I think it's a little bit older. But anyhow, another 36-year-old woman. Interestingly, she had a AKT mutation, and I see she also had capecitabine, TDXD, and sacituzumab before she ended up getting fulvestrant and capivasertib. What happened while she was being treated?
Yeah, this is before we had CAPI.
Right.
We knew the AKT was causing her a whole lot of trouble. She didn't respond to capecitabine nor TDXD. Interestingly, she did respond to SASI for 9 months. But it is very, very destructive disease and lots of radiation therapy, a lot of morbidity. But we didn't have CAPI. So as soon as we got CAPI, I put her on it with fulvestrant and capivasertib, and within like a week, she's back in the office. Dramatic improvement, the bone pain dramatically, she needed that drug, and so it was really, really great to see that, because she was really refractory, heavily pretreated at that time, and she had about 10 months. She did great with it.
And I haven't heard anybody bring up, I'm not sure if I heard you right, but do you think the phenotype of AKT
Is bad.
disease is bad, really?
Oh, yeah, from what I've seen, Neil, yeah, and I've seen it before, and that's why we've been waiting for CAPI for so long, because we didn't have it, and it's a bad cancer.
I don't know if I'm the last one to hear that. Dita, you agree with that AKT is associated with a more aggressive phenotype?
Looks like, and like with this patient, young patient with aggressive disease that didn't respond to capecitabine or TDXD, we don't see that. Usually tumors do respond to these agents, so glad this patient got CAPI.
I'm not sure that's true. I've got a patient who has had indolent ER-positive metastatic disease for about 9 years, and she had an AKT1 mutation and also had a very beautiful response to capivasertib. But her disease has been, managed, smoldering for a long time. I don't know how robust those data are.
Is it acquired? Was it acquired? Mostly it's in the primary AKT. You can acquire it. It's like PIK3CA. And sometimes, another patient coming to mind, she was young. Again, another one. She did great on CDK and AI for a long period of time. But when she progressed, that's when the AKT took over. It was really difficult to get her durable response. You know what I mean? She would respond briefly, but that's a very, very strong survival and resistance pathway. So they can do well for a while, but then once that AKT takes, it's kind of like PIK3CA. When PIK3CA takes over, it's a whole nother ball game, basically.
I don't know if I have a bad memory or it's just clogged with stuff, but it's amazing how often I feel like I'm hearing things for the first time, and I never actually thought about this, but so AKT and PTEN is acquired?
PTEN's acquired. AKT's in the primary mostly. You can acquire AKT.
So do you need to do repeat assays to find it? Because it's not necessarily there?
Yeah, and we do
ESR1?
that, as you know, we do that in the metastatic with every progression.
But not with PIK3, because PIK3 is either there or not there. Is that right?
You can get that 10% of the time, too.
Really?
Yeah, in Paloma 3, 10% of patients acquired. Now, whether it was true acquisition versus it just showed up in the blood, is a different question. But you can find it in the blood. That AKT or PIK3CA, if you keep looking serially, you can find it 10% more than you can find it up front.
So let's move on and talk about oral SERDs. And again, this one of the major presentations at the San Antonio. There's always one or two really important presentations, and one of them this year was the EMBER-3 study. So we're going to hear a little bit about oral SERDs from Joyce.
Okay, great. So I will go relatively quickly here. So as Hal said, the ESR1 mutations are acquired. You only find 1% in the primary, 30 to 50% post-AI, particularly in the metastatic setting. But it's one of the main drivers of acquired endocrine therapy resistance. It's in the ligand binding domain, mostly those mutations. And so it heterodimerizes with either a wild type ER, it can heterodimerize with AR, but then it does not need a ligand. No ligand does not need estrogen, and it binds really, really tightly to the estrogen response elements and drives transcription without a ligand. So it's interesting, it's still ER-driven disease, but it's a mutated ER, and we just haven't had any good tools to basically inhibit mutant ESR1 until now. The point on the left here, if you look at ESR1, the yellow and the orange are when there's concordance between the results of tissue, NGS, and blood ctDNA. But the purple is when there's discordance, where you're going to miss it on the tissue, but you'll find it in the blood. And that's really kind of the story of ESR1. And the reason is maybe over on the right is that not all of the metastatic lesions will acquire this ESR1 mutation. It may be subclonal, but the blood kind of integrates the progression across all of the metastatic sites, and so you're more apt to pick it up in blood, as opposed to like biopsy one of the metastatic lesions and do NGS on that, you might miss it. But the blood, anything that's growing should be shedding into the blood. So the oral SERDs have a lot of advantages, of course. They're oral rather than IM. They've got established activity post-CDK4/6. They're more highly potent than fulvestrant, and they really have good activity against ESR1 mutation. So Aditya led the Emerald trial, and these patients had all had a prior CDK4/6 inhibitor. And they were randomized, regardless of ESR1 mutation status, to elacestrant versus mainly fulvestrant. Like 20-25% of the patients had an AI because they already had fulvestrant, but mainly it was fulvestrant versus the oral SERD elacestrant, all post-CDK4/6. And you can see all patients on the left and then ESR1 mutant patients on the right. And the median differences are pretty small because there's still about, even on the right there, about 40% of patients that are resistant to the endocrine therapy. But then for those that are still sensitive to endocrine therapy, the curve split like really substantially in favor of the elacestrant. That's one of our challenges, is to find out who those 40% of patients are. And then it was reported by Virginia and Aditya that if patients were endocrine therapy sensitive and the surrogate used was, they got at least a year benefit from their prior CDK4/6. So they had an 8.6-month median PFS. They were ESR1 mutant and got at least a year on their prior CDK4/6, 8.6 months. That's very good, for a median. Half will be longer, half will be shorter. So that became kind of the standard of care to offer elacestrant to the mutant patients who did well on their prior CDK. Now, on the right is PIK3CA wild type and Emerald, and you can see that patients did substantially better with the elacestrant, and these are ESR1 mutant and PIK3CA wild type. The elacestrant really outperforms the standard endocrine therapy a lot. It also outperforms it on the left with the mutant population, but the median PFS here is 5.4 months. Certainly better than 1.9 months with standard endocrine therapy, but of course we'd really like to inhibit both PIK3CA and ESR1, but still there is a subset of patients that you can give the single agent elacestrant to. I totally agree with what Aditya said, who he would offer that to. Regardless of bone metastasis on the left, liver lung metastasis on the right, the elacestrant was substantially better than a single agent standard endocrine therapy. This is in the ESR1 mutant population. So clearly, we finally had an agent that could really inhibit these very, very active and driving ESR1 mutations with almost no toxicity. Very slight nausea that tachyphylaxis and goes away. If you take it with food, it's much better. It goes away. So really extremely well-tolerated agent. So elacestrant now is being put together in combination with all the other targeted therapies, all the CDKs, alpelisib, capi, everolimus, and Over on the right, you see these are heavily pretreated patients, but elacestrant plus abemaciclib, we see nice responses. And down the bottom, elacestrant plus everolimus, very active as well. And basically, the only toxicity is from the targeted agent. The elacestrant doesn't really bring any toxicity, so combines very well with all of the standard targeted agents. We've seen the same story, which is on the top, we see a different oral SERD, giredestrant, that is being studied in the first-line metastatic setting and in the adjuvant setting. But when you test it against standard chemo, this is fulvestrant. So up at the top, it's fulvestrant versus giredestrant. You see that they're identical. And that's what all of the studies show, is that the oral SERDs are just as good as fulvestrant in the wild-type population, but all of the studies also show down the bottom right that they're better than fulvestrant in the ESR1 mutant population. So it's a very, very consistent story. And again, here's the SERENA-2 with camizestrant. Now that the top two lines on the Kaplan-Meier are two different doses of camizestrant versus fulvestrant. Again, really, really good evidence here. And this isn't in all comers, but really good evidence that the oral SERD is better than fulvestrant. Now, if you do a subset analysis, all of the benefit is in the ESR1 mutant population in terms of the superiority to fulvestrant. But again, camizestrant, another agent, very, very effective against ESR1 mutant patients. So down the bottom right, we just talked about SERENA-6 and whether or not we're going to be bringing an oral SERD into patients in that, quote, first-line setting where the ESR1 comes up and you leave them on their CDK and you take them off their AI and put them on camizestrant because they got the ESR1. It'll be really interesting to see, once we all see the data, what we all decide to do. I'll show you the EMBER-3 here in a second. And then Persevera and SERENA-4 are first-line trials of CDK4/6 palbociclib with either AI or with the oral SERD camizestrant or giredestrant to see if the oral SERDs are better than AI in the first-line setting. So we have to have a way to sequence these therapies, and we heard from Ginger about the post-Monarch, where everybody had a CDK4/6 with an AI, and then they were randomized to fulvestrant plus minus the abemaciclib, and there was definite benefit from the abemaciclib. But what about imlunestrant? Let's bring in a different oral SERD, and let's look at it in the wild-type population, ER, and in the ESR1 mutant population. And so in EMBER-3, 60% of patients had a prior CDK4/6 inhibitor, 40% were naive, so it was a mixed population. And it was an all-comer population, big trial, imlunestrant, the oral SERD, versus fulvestrant or exemestane, again, most got fulvestrant, versus imlunestrant plus abemaciclib, and they looked at both the overall population and the ESR1 mutant population. And the ESR mutant was about 40%, PIK3CA was about 35%, and as I said, CDK was about 60%. And so on the left, in the ESR1 mutant population, we see that imlunestrant was superior to standard of care endocrine therapy. We see a hazard ratio of 0.6 and a highly significant p-value, but that was actually not the case. It was not significant in all patients. So again, we saw that imlunestrant superior to standard endocrine therapy in ESR1 mutant patients. But then when you compare imlunestrant plus abemaciclib versus imlunestrant, regardless of ESR1 mutation status, which I'll show you, we see a really big, very nice improvement in PFS, and we see the hazard of 0.57, and we see median PFS up at 9.4 months with imlunestrant plus abemaciclib. And up at the top is top left with ESR1 mutation, top right without an ESR1 mutation, bottom left prior CDK4/6, bottom right with PIK3CA mutation, pathway mutation. So this combination of imlunestrant and abemaciclib was superior to imlunestrant regardless of molecular subtypes. It's almost like you don't even have to look. This is better than single agent imlunestrant regardless of molecular subtype. And in the prior CDK4/6 patients, it was 9.1 months in all comers with the combination. And the response rate down the bottom there, the red is the combination, and the blue is imlunestrant, and the gray is the standard of care endocrine therapy. There's a trend towards survival in the imlunestrant versus standard endocrine therapy. You can see the trend there with ESR1 and all patients, and it's early yet. The combination of imlunestrant plus the abemaciclib started a little later. That was added to the trial a little bit later, so we're very, very early yet on survival, so we have to wait for that. Again, the only toxicity is due to the abemaciclib. The imlunestrant is extremely well tolerated. And then Hal gave the discussion of the EMBER-3 at San Antonio. Very nice discussion. And he put this together, and he was caveats, this is cross-trial comparison, et cetera. But looking at patients who had a prior CDK4/6 inhibitor, what do we do next? And there was a number of single agents we could use, fulvestrant. We could switch to a different CDK4/6, like go from palbo to ribo. We know palbo to palbo doesn't work. Post-Monarch, we can go from AI, palbo, ribo to fulvestrant and abemaciclib. We can bring in capivasertib. And then the EMBER-3, we can see over on the far on the right, is you get your 9.1 months in your prior CDK with imlunestrant plus abemaciclib. So Hal just pointed out that, that's the biggest median PFS we've seen to date post-progression on CDK4/6. And then I've also stolen this from Hal's discussion. And it's just interesting. In the green, Hal put in where we might, if it's approved, once we have it approved, where we might consider the imlunestrant plus abemaciclib. And you can see it's mostly in that second line setting, and it's kind of regardless of ESR1, regardless of PIK3CA, AKTP10, because we saw evidence of benefit in that group as well. And then I would like to suggest possibly as well, if we move over to the first line setting in patients who had already had, if they were recurring on their adjuvant endocrine therapy, if they were recurring on adjuvant AI down the bottom, that right now it's fulvestrant plus CDK is the standard, but those patients were eligible for EMBER-3, so we could put the imlunestrant abema in that box. And then even down the bottom in the PIK3CA, where we give the inavolisib triplet, because they're recurring on their adjuvant AI, we give them the inavolisib triplet, those patients as well were eligible for EMBER-3, so we could put the imlunestrant abema in that box. And so when it's available to us, we're going to have a lot of choices in the first, second, and third line. And then when we add in the switching to camizestrant, continuing the CDK4/6, we're going to have to update this box once we see those data and see where we're going to use that. So that's it.
So yeah, EMBER-3 has been one of the great challenges for me to try to figure out. Let me take the next step on that. Actually, maybe we'll work our way back. Hal, she suggested maybe you ought to think about changing your last slide here and think about it first line. Any thoughts about that? Do you actually think that the imlunestrant abema combination is going to be approved?
Well, the first thing you say is I'm looking at my own slide and I'm thinking that's a really complicated slide. So beware what you put together. So, when tumors progress on an AI and a CDK4/6 inhibitor, there are really three types of cancers in that space now. The first are the tumors that are ER positive with a wild type mutation. And some of those are still really sensitive to endocrine therapy. And some of them are completely resistant to ongoing endocrine therapy. We don't really have a good marker for who's who. And then there's a third group which have this ESR1 mutation. And the most important thing to remember about those is they're exquisitely dependent on estrogen receptor. Darwinian selection has said that cell needs the functioning estrogen receptor, and so much so that it mutated it to make sure it would keep going. So the advantage of the oral SERDs is largely a pharmacologic one. They get much higher doses of the estrogen receptor degrader into the cells more quickly than traditional fulvestrant, which for those of you who've given the drug know it's an injection, it's every month. Even with the loading dose, it takes months to get up to a therapeutic level, and that therapeutic level is less than a third of what you get with imlunestrant. So mostly this is better pharmacologic availability for an otherwise very well-tolerated treatment approach. In the near term, I do not imagine that FDA would approve the combination, but these days, we're living in unusual regulatory times in a lot of spaces, so who knows what they're going to do. The problem is that the curves still show us negative survival signal for imlunestrant abema versus imlunestrant. So, it seems a little funny to imagine approving a drug in that setting. I assume that will be a reflection of limited follow-up. What was exciting about the combination here, and I don't know if you can scroll back a couple slides, was that in the cohort of women who'd already had a CDK4/6 inhibitor, and you compared imlunestrant abema versus imlunestrant, here's the slide, it's your lower left corner. It really looked like there was benefit, and that benefit was seen largely irrespective of the ESR1 mutation. If that's the case, and this is validated in things, then this is the first of the SERDs that is sort of broken out of the ESR1 box, if you will, and seems to be a little better than fulvestrant. But as Aditya has already alluded to, there's a missing arm in this trial, which is, would fulvestrant abema by itself have achieved similar results in the ESR wild type, and we don't have that from this study.
There's a question from the audience, Hal, that kind of relates to what you're saying. The person wanted to know, does fulvestrant work in patients who are ESR1 positive? Do you see a differential benefit with fulvestrant the same way you do with the oral SERDs?
In the older literature you did. So there are older trials where they looked at fulvestrant versus an aromatase inhibitor in tumors which had ESR1 mutation. There was a clear advantage for the SERD, the fulvestrant, in that setting as well, if I'm answering the question that was posed, yeah. So it's great that we have these options. I do not know, the algorithms are going to become impossible to write because of the options that people have. And especially if multiple products enter the same space of, first line or second line treatment. So, that's a good problem to have. Maybe, truly electronic health records or some other system will allow us to sort it out. But I thought what was really provocative about EMBER-3 is it did seem like in those patients who had prior CDK4/6 exposure, continued the CDK4/6 plus the SERD as opposed to what we see with a fulvestrant. We were really sort of beginning to move the needle a little bit more.
So just to finish this out, and then we got some other questions from the audience I'd like to address. But Joyce, you pointed out something I didn't really appreciate at first. These SERD trials are comparing it to other endocrine therapies. So it's not like not endocrine therapy. So even though it's not, quote, an equivalence trial, it looks like it has a similar benefit. And you do see benefit when it's ESR1 wild type, which leads me to the question is, like, how does it really, is it just degrading the receptor, or are there other mechanisms involved that contribute to the anti-tumor effect?
As far as I know, it's really just degrading the estrogen receptor. It's just that fulvestrant, and I don't think we have understanding for all of the ESR1 mutations, but the Y537S, fulvestrant doesn't work very well against that. It works pretty good for the D538G. It works pretty good, but it does not work for the Y537S. And those are the two main ones that we have. I think we're going to learn more about that. So I think that's why there's the differential benefit, whereas fulvestrant works pretty well against the wild type. But the thing is, all of these SERDs work equally well to fulvestrant, so it'd be nice not to take the shots. I'd like to have it for the wild type as well.
So Ginger, Hal's talking about all these algorithms. Of course, what we do is just ask people what they do. And maybe we'll ask 100 scenarios rather than 5. I know that may not be as scientific as some of the evidence-based algorithms, but a couple of questions from the audience. Maybe you can take this one, Ginger, about creatinine increases with CDK inhibitors. How do you determine whether it's real renal toxicity? Do you hold the drug? I never heard of ioxyl clearance. Maybe you have in terms of renal function. How do you approach the patient with increasing creatinine on a CDK inhibitor, Ginger?
Yeah, I think we've learned and gotten more comfortable with the fact that it's a laboma as opposed to an actual impact on the patient's creatinine. You can check I believe it's cysteine C is the lab that you can order to try to get a handle on is it real or not, particularly if you have a patient who doesn't really have a reason to have an underlying impact on their kidney function. They don't have underlying other comorbidities. They're not taking other medications or having a lot of GI issues where they could be becoming dehydrated in a way that would also affect their kidneys. You can pretty comfortably put that to rest and not necessarily pay a lot of attention to it, as long as it's not, something that's increasing logarithmically. That's not normal. If it goes up a scooch, perhaps even a bit out of the normal range, you can look at that and go, they're taking their medication. So I use it as a sign of compliance sometimes. But it does lead to a lot of consternation if the patient gets admitted, let's say, I don't know how it is in Florida, but in Colorado, flu is everywhere right now. So I have more patients admitted for viral infections than ever before. And when they're admitted, the inpatient hospitalists get very concerned and start doing all of this large workup. And you have to kind of get in there and say, wait, we're okay here. But be careful if they have underlying kidney issues. Then you need to be a little bit more thoughtful. And if they have a nephrologist, talk to them.
So
have you seen this with anything besides Abema? I thought it was unique to Abema.
No, I've seen it with Ribo.
So, Aditya, tomorrow we're going to talk about, when we talk about HER2-positive metastatic disease, we're going to get into the issue of TDXD and brain mets, but there's a case that was just submitted that sort of ties into that a little bit. I wonder what your thoughts are. This is a patient who progressed on adjuvant letrozole, then progressed on fulvestrant everolimus, then on alpelisib. Sounds like they had a PIK3 mutation, and now progressing with small brain mets. So assuming they're small and asymptomatic, but now the patient has an ESR1 mutation. So elacestrant or TDXD. She has HER2 2+.
Yeah, so she's asymptomatic, and if the disease is predominantly in a bone, you could certainly consider elacestrant. Elacestrant does cross the blood-brain barrier, and there's an ongoing study looking at elacestrant alone or in combination with abemaciclib, specifically for patients with brain mets. But similar to what was said previously by Ginger, in such patients, I would do scans earlier. I would not wait for 4 or 5 months to get my restaging scans, more like 2 months, because if it's not working, I would want to know early.
That's a great point. So getting back to the old what do they do type thing, here are a couple more abstracts that we have. This is a 65-year-old lady who gets adjuvant anastrozole, then CDK inhibitor and fulvestrant, responds, then has disease progression, ESR1 mutant. It's sort of a classic elacestrant situation. Most people would use elacestrant in that situation. Now we say, Ginger, that the patient progressed 6 months after being on a CDK inhibitor, fulvestrant. You'd say this is kind of endocrine resistant. Now you still see a few people saying elacestrant, others saying other forms of endocrine therapy, but a lot of people saying capecitabine. And it gets into this question, as I was sort of alluding to before, how much of a quick progression on a CDK inhibitor will get you to at least temporarily get away from endocrine therapy.
I think we've seen data presented tonight, and this is hearkening back to a question we talked about a little bit ago. This patient would be a good candidate for the elacestrant, and I really like the way you put it, Hal, that is nature telling us what is the driver of the cancer. And as always, when you're worried that you might not be making the optimal choice, you can watch the patient a bit more carefully. I think now, in the setting of the post-MONARCH data, we also could consider the fulvestrant and abemaciclib option, which didn't get a lot of love in this slide. We don't know that would be negatively affected by the ESR1 mutation from that study per se, but we certainly saw that patients, even with a sooner disease progression, did okay on that choice. I think we often reach for capecitabine because it's chemo, and we have the sense that chemo is better than these other combos, and I think we're seeing a lot of emerging data that it isn't always, particularly not an oral chemo like capecitabine.
Hal?
I just want to make a point. As you read the papers that come out in this space, there's a lot made of the exposure length for CDK4/6 inhibition. There's nothing magic about that. It's just another sign of endocrine sensitivity of the tumor. So if they're on it for 18 months or 12 months minimum, those in general are going to be cancers that are still more endocrine sensitive than someone like this who progresses in 6 months. And I think that there's no... the the presentations often imagine that there's like a real, oh, like this is a clinical group. If they have 12 months or more, then you get this or not. It's just clinical's common sense, which is they've done well for endocrine therapy with the CDK4/6 for a long time, probably going to continue in that vein, versus pretty quickly resistant to your ongoing endocrine therapy, probably time to move on to a different treatment approach.
So Joyce, the challenge of indirect comparison of agents in the same class is something we're going to be talking about all weekend. We talk about all the time. Now that there's so many new agents out, often similar agents in the same class, you're stuck with indirect comparison. So we asked this same group again what their thoughts were in terms of efficacy and tolerability. In general, they felt that the efficacy was about the same, tolerability about the same, although 5 people said they thought elacestrant was more tolerable. Any sort of personal experience you want to relay, Joyce, in terms of tolerability or efficacy? Any thoughts you have? Any situations where you think one is better? And also, I'm curious from the entire group, some of the sort of unusual things we're hearing about oral SERDs, photopsia, bradycardia. Hal brought up in his discussion something I never heard about was hypertriglyceridemia, right? Any thoughts?
I agree. I think the efficacy is about the same in the ESR1 mutant population. I think the tolerability is very, very good for all of them. I've not seen the photopsia or the bradycardia. The 75 milligrams is what's been chosen. It's very, very small chance of those things. I have a gal on EMBER-3, and she's about 3 years out on her imlunestrant. She is doing fabulous. She's a bone only, just fabulous. So I actually have not had issues with tolerability for any of them.
You know anything about the triglycerides? How you brought that up? Was it just elacestrant?
Well, I mean, so certain ones, giredestrant, I think, has the triglyceridemia. A couple of them have the photopsia. There's bradycardia with some of them. I've only given one patient imlunestrant. It was on a trial. In the report in EMBER-3, imlunestrant was a really, really well-tolerated drug. I mean, it had none of these other side effects. So if that, proves to be the actual clinical experience, I would say it is, at least in the reports to date, the most tolerable of these agents.
Ginger, it looks indirectly, in the imlunestrant monotherapy arm in EMBER-3 looks a lot like what was seen with elacestrant. Would you like to, actually I asked that we had 9 faculty people in 2 meetings. After EMBER-3 came out, I said, would you like to be able to use imlunestrant monotherapy, yes or no? Would you like to be able to use imlunestrant plus AI, yes or no? And they all said yes to both things, although one person said, I don't know if we need another, monotherapy option. Are there situations where you'd like to use imlunestrant monotherapy?
Yeah, I like having options. So I would love to have the opportunity for imlunestrant monotherapy. I think in terms of the tolerability, the funniest thing about the bradycardia is it's because everybody wears one of these on their wrists.
Right.
Nobody is symptomatic. So they get told by their watch that their heart rate is lower, and that is a phenomenon of the modern era in these drugs. For all we know, if these things existed back in 1998, maybe fulvestrant would have done it too. I believe you also said the imlunestrant plus an AI, which I don't
I'm
know.
sorry, CDK.
Oh, okay, yeah.
Abema.
I don't want to go back to all those studies we
Sorry.
did 20 years ago of combining this with that because we have no other opportunities. I think combination targeting for the right patients makes a lot of sense, and ultimately we are seeing all these studies with almost octopus level of arms combining with the different partners out there. It's going to get harder and harder to know, and so as we know from prior experience, like when the 3 AIs came about and the 3 CDK4/6 inhibitors came about, people will vote with their feet. It'll be their personal experiences. I also like to remind the people who make these drugs that the easier you make my life to give your drug and the less phone calls I have to get from my PharmD to get it approved, the better. So there's many ways in which these things could rise to the occasion of being the one we will use the most. But I think the data from EMBER-3 is compelling. The side effect profile is compelling. I would like to see that as an opportunity. And I'd love it if we could get one of these in the non-ESR1 restricted space like we had fulvestrant from the get-go.
So before we get to a case here, another question, Aditya from the audience. Interesting question. Does ER level affect your treatment decision making? And also, I'm going to add to that, what about ER low? Under 10, do you treat that as triple negative?
Yeah, so in general, in the metastatic setting, we don't do repeated biopsies, but if you have a biopsy that shows that the tumor is, ER, PR positive versus ER low, in the latter setting, I would be more hesitant towards endocrine monotherapy. I could consider combination therapy. So someone has ER low disease with PIK3CA or AKT mutation, use of endocrine therapy plus another genotype-directed therapy. The value of ER low can be in the setting of immunotherapy. So if a patient has ER low disease and it's PD-L1 positive, that is a setting I would consider pembrolizumab with chemo.
Yeah, that's what I've heard that before. I never actually thought about it. So, Al, you have a patient who went on elacestrant. What happened?
This patient is different than the other one. She had ribo and letrozole. She progressed to TDXD, progressed after radiotherapy, and now had a repeat biopsy done at the time of radiofrequency ablation at an outside hospital, which showed the tumor was still ER positive, as it usually is. It's rare to lose all ER in these cases. And she had a specific ESR1 mutation, to Joyce's point, the DE538G1. And so, I thought she was a reasonable candidate for elacestrant in this setting. I actually saw this patient in consultation. She'd been advised to take elacestrant plus abemaciclib based on the EMBER-3 data, and I would not make that inference. I mean, we really don't know the safety or benefit of that dual approach in this setting. So I think you might have chosen either abemaciclib or elacestrant, but I would pick one or the other for the time being until we have more indication that that combination is helpful and safe.
How did she do on the elacestrant?
She's just getting going. We saw her just a few weeks ago, and she'd had this liver ablation done at an outside hospital, and we don't usually do that either, for the record. But she was hopeful that it was going to buy her, a high quality of life and progression-free survival benefit down the road, so she could continue on endocrine therapy for a longer arc of time.
Ginger, any thoughts about liver ablation for liver mets?
15, 20 years ago, when we didn't have all these great targeted therapies, I felt like it was worth a try. And after having given many a try, I would say there's no real reason to do it. We did, in this case, this patient had been quite heavily pretreated, so I think there really is no indication. Even in the setting of upfront oligometastatic disease, when we ran the NRG BR002 trial, we couldn't show a benefit to the ablation. There were lots of caveats of that study because it tried to be very real world, and I think in that regard it somewhat shot itself in the foot because all the things like the CDK4/6 inhibitors and these targeted therapies came along, and that was not incorporated to the overall systemic therapy. But certainly in a patient as heavily pretreated as that, unless there is a local issue you are very much targeting to benefit the patient for, say, a top of the dome of the liver capsule, a lot of pressure, a lot of pain, and you're worried, given the level of prior treatment, there's not going to be a fast response, and this is for quality of life. That would be the only reason I could reach for a local therapy like that anymore.
So, Didi, we're going to finish out talking about antibody-drug conjugates, something I feel we talk about every day doing CME. Now we have another ADC approved in the ER-positive metastatic subset.
Great. So I'll review ADCs for ER-positive breast cancer. Some of my disclosures. So ADCs essentially are a way of giving more doses of chemotherapy or toxic payload, preferentially to cancer cell. At least in principle, that's the idea with ADCs. The ADC binds to an antigen, gets internalized, releases the payload. Newer ADCs also have bystander effect, and that's a way to address antigen heterogeneity, which becomes relevant as we talk about HER2 low and HER2 ultra low as well. So the DESTINY-Breast04 trial established TDXD for HER2 low metastatic breast cancer. It was largely for hormone receptor positive breast cancer, 90% of the patients in the trial, and that was the primary endpoint as well, PFS in patients with hormone receptor positive breast cancer. 10% of patients in the trial had hormone receptor negative disease, which was a secondary endpoint looking at PFS in all patients. In terms of outcomes, it was presented at ASCO and then ESMO as well with additional update, clear improvement in progression-free survival as well as improvement in overall survival with the use of T-DXd as compared to standard chemotherapy. So this was a practice-changing study that led to the approval of T-DXd for HER2-low metastatic breast cancer, both hormone receptor positive and hormone receptor negative. In terms of side effects, 3 common side effects with T-DXd include nausea, which is the #1 side effect, can cause some myelosuppression as well. And the third side effect, which has received a lot of attention, is pneumonitis that can be seen with T-DXd, including deaths or grade 5 toxicity with T-DXd. In Destiny Breast 04, overall incidence of pneumonitis or ILD was 12.1%, and that's what most studies have shown, range of 10 to 15% in terms of pneumonitis. In this trial, most of the pneumonitis was grade 1, grade 2, although 3 patients had grade 5 ILD with T-DXd. So how about lower HER2 expression? If we look at the expression of HER2 by IHC, HER2 low essentially is an operational definition for tumors that have some degree of HER2 expression. HER2 2+ is expression of HER2 in more than 10% of cells. HER2 1+ is also more than 10% of cells, but it's incomplete membrane staining. What if it's less than 10% of cells? So let's say 2% or 4% or 6% of tumor cells having HER2 expression. That was traditionally considered IHC 0, but it has led to this new operational definition of HER2 ultra low. So that is less than 10% of tumor cells having some HER2 expression. So from a pathologist perspective, if you're seeing any brown staining, even faint brown staining, that would be considered HER2 ultra low. And some have even said that essentially HER2 IHC 0 would not exist because you can always find some HER2 staining in these cancer cells in ER-positive breast cancer. So this was evaluated in DB06. It was different from DB04 in that it did not require prior chemotherapy. So after endocrine-based treatment, the next option was T-DXd versus chemotherapy of physician's choice. The second difference was the trial also included HER2 ultra low besides HER2 low. In terms of outcomes, the study met its primary endpoint. There was improvement in progression-free survival as presented at ASCO last year, median progression-free survival of 13.2 months. So besides CDK4/6 inhibitor, this is the second agent that has shown a median PFS of more than 12 months in the setting of hormone receptor-positive metastatic breast cancer, the hazard ratio 0.62. Similar results were seen in HER2 ultra-low metastatic breast cancer as well. And if you look at response rate, the response rate was very similar between HER2 low as well as HER2 ultra low breast cancer. Response rate of 61%. So majority or more than 50% of patients had partial response, and some even had complete responses in HER2 ultra low as well as HER2 low setting. So the drug does work in HER2 ultra low as well besides HER2 low. We were talking, so this led to the approval of T-DXd for metastatic hormone receptor positive, and this was both for HER2 low as well as HER2 ultra low. And because DB06 did not require prior chemotherapy, that requirement was removed when the FDA approved T-DXd based on DB06. Other drugs in this setting, sacituzumab govitecan, it's a first-in-class TROP2-directed ADC, targets TROP2, has a high drug-to-antibody ratio, also provides a bystander effect. The payload is SN38, the active metabolite of irinotecan. It showed improvement in progression-free survival in triple-negative breast cancer in the ASCENT study, and then in the TROPiCS-02 study, showed improvement in median progression-free survival as compared to standard chemo. What was more exciting was the improvement in overall survival seen with sacituzumab govitecan versus standard chemo, a median overall survival of 14.5 months. In terms of side effects, so the drug has SN38, and the side effect profile is similar to what we see with irinotecan. So neutropenia being a common side effect, diarrhea, nausea being other AEs that are seen, as well as alopecia. overall incidence of neutropenia grade 3 or higher is 51%. So 1 in 2 patients will have neutropenia without, if you don't use any prophylaxis, that'll require either holding SG or reducing SG if it takes a while for neutropenia to improve. The third drug on this block, which was recently FDA approved, is datopotamab deruxtecan, or Dato-DXd. It targets TROP2, but is quite different from SG. First, the antibody is different, is datopotamab as opposed to sacituzumab. Second, the linker is different as well. It's a tetrapeptide-based linker, which is more stable than what is used in sacituzumab govitecan. And the third difference is deruxtecan is the payload, which is more potent than SN38. But the drug-to-antibody ratio in datopotamab deruxtecan is 4:1 as opposed to 8:1 with sacituzumab govitecan. So while it has a more potent payload, the drug-to-antibody ratio is lower. In terms of efficacy, this was evaluated in TROPION-Breast01 study, a trial very similar to DESTINY-Breast04. So after 1 line of prior chemotherapy, randomization to Dato-DXd versus standard chemo, you could see improvement in progression-free survival with a median PFS of about 7 months. Interestingly, in terms of overall survival, the results were just presented a couple weeks ago at virtual ESMO plenary. There was no improvement in overall survival with Dato-DXd as compared to standard chemo. So the team then looked at the use of subsequent ADC. Because this was after 1 line of chemotherapy, patients could have received Dato-DXd, and then after Dato-DXd could have received T-DXd or SG. Patients in the control arm, after they had disease progression, could have also received T-DXd or SG because those drugs were FDA approved. And there was imbalance in the subsequent ADC use between the 2 arms. So the team did additional analysis balancing for this imbalance. And if you balance the subsequent post-ADC use, you do see a trend in favor of Dato-DXd in terms of median overall survival, 19.1 months as opposed to 17.5 with standard chemotherapy. So it appears that some of the difference in overall survival was because of the imbalance in the subsequent ADC use. In terms of side effect, while this is a TROP2 ADC, the side effect profile is quite different from both T-DXd as well as sacituzumab govitecan. The drug does not cause much neutropenia. The incidence of neutropenia was 1% with Dato-DXd and was much lower than what was seen with standard chemotherapy. But the side effects that you see with Dato-DXd include stomatitis, which is the #1 side effect, as well as keratitis. So a different side effect profile as compared to the other ADCs. In terms of pneumonitis, the incidence of pneumonitis is lower as compared to T-DXd. Maybe it's because of the lower drug-to-antibody ratio, but it is a side effect that can be seen with Dato-DXd. Pneumonitis generally is not seen with sacituzumab govitecan, so that does become important when we have these different drugs. In terms of prior history of pneumonitis, there might be an ADC that is prioritized over the other ADCs. Now, besides this, there are other drugs in development as well. Sacituzumab tiromotecan is a TROP2 ADC that is in phase 3 clinical trials. You have HER3-DXd as well as disitamab vedotin, which is a HER2 ADC. So a number of ADCs in clinical development. Most of them have TOP1 inhibitor as the payload, but a couple of newer ADCs have microtubule inhibitor as the payload. And so that could have an impact related to ADC success in the advanced setting, especially if they are used after, say, T-DXd. If you use a similar payload, there might be some cross-resistance. So as we think about sequencing the different ADCs, we'll have to think about not only the antigen, but also the payload. An example from our group showing that if you develop TOP1 mutations, you have cross-resistance to ADCs with similar payloads. So if you use T-DXd followed by Dato-DXd or T-DXd followed by SG, in the presence of TOP1 mutation, there'll be cross-resistance. But on the other hand, if the resistance is more related to the antigen, then you switch from T-DXd to SG or T-DXd to Dato-DXd, that would still work because the resistance is more related to the antigen. So understanding resistance, whether antigen-related versus payload-related, could help in sequencing. We now need clinical biomarkers so that we can apply this in clinic. It's not ready for prime time yet. So this is my algorithm for the management of hormone receptor positive HER2 negative breast cancer beyond second line. We talked about first line, second line. After patients have exhausted endocrine based options, TDXT is potential option to consider, although for some patient, capecitabine might be preferred before TDXT. It's a patient-centered discussion. If you use TDXT first, then after that you can use capecitabine or vice versa. For patients with HER2 low or ultra-low disease, after TDXT, sacituzumab govitecan or now datopotamab deruxtecan would be potential options to consider. For IHC completely zero or null, sacituzumab govitecan and datopotamab deruxtecan would be potential options. So in summary, TDXT is now approved both for HER2 low as well as HER2 ultra-low metastatic breast cancer, no prior line of chemotherapy required. Datopotamab deruxtecan is approved after 1 prior line of chemotherapy. Sacituzumab govitecan approved after 2 prior lines of systemic therapy. And there are multiple other ADCs in clinical development, so the landscape is likely going to change further.
I was just flashing on the fact there was an incredible education session at the San Antonio meeting on ADCs and breast cancer. I really recommend it's online. You can watch it. I learned a lot about the issues of resistance that come from the target or the payload. It's just really a great discussion. Quick follow-up, Aditya, from the audience. Do you check UGT1A1 in patients getting SASI?
Not at this time. In the FDA label as well for SG, there's no requirement for testing of UGT1A1. If a patient starts SG, they have side effects, you can always dose reduce. So I use more the AEs to guide the dose of SG rather than UGT1A1.
Makes sense. Ginger, getting into HER2 low. First of all, how often do you see HER2 zero? Like nothing. A couple of the cases were labeled HER2 zero. I don't see that too often nowadays. Another related question, the HER2 ultra low study was done in ER positive disease. Will you treat ER negative HER2 low, ultra low also?
So to the first question, I think there's 2 ways of figuring out your patient's protein expression of HER2 in the metastatic setting. You can go back and pore through the prior pathology reports, and if any single one of them says 1+ or 2+-ish negative, you're done. You can give that patient the right to try. If they do say 0, then you can see if you have some tissue in the metastatic setting to try and rerun. You could go pull the old slides and rerun, and you can have a conversation with your pathologist of what you are asking them to look for. But the biggest problem we are facing right now is we are trying to turn a screw using a hammer. The test we use to look for the level of HER2 expression on the surface of the cells was never designed to do this, and our pathologists weren't trained on how to do this. So we really need rapid progression in that space to know what we're doing, or the alternative is to say maybe HER2 zero is irrelevant based on some of the emerging data that we're seeing, and give everyone the right to try. It's been a long time coming to be able to use something that is HER2 targeted in the HER2 low space, and it took the ADC with the DXD payload to get us there. To the second question, in the TDXD data, there was a small percentage of patients that were triple negative that were included, not in DB06, but in DB04, that didn't incorporate the HER2 ultra low. So it would be a data-free zone to do that, so probably safer to try and retest and find a level of HER2 expression. There's evidence out there now that if you do serial biopsies and you do up to like 5, you'll eventually get a HER2 score that will get you into the realm of using this drug. But I don't think that's a very patient-facing approach. Multiple biopsies is not a great thing. So again, we need better biomarkers, we need better tools in the toolbox to know how to use this. For now, I think maybe retesting and having that conversation with your pathologist goes a long way. If they're truly, truly, truly on repetitive testing, always HER2 zero, then I would not give them something HER2 targeted.
What about ultra low hormone receptor negative? You use TDXD?
Well, again, that's a data-free zone because that wasn't in DB04. So you'd have to be taking a leap of faith there to do that. I think the better part of Valor is to maybe find a result that isn't ultra low if you can.
So Joyce, any thoughts about Dato-DXd? Where do you see yourself using it? And can you comment on the mucositis? You've been really a leader in some of the earlier studies with mTOR inhibitors, et cetera. What's your experience with Dato?
Yeah, everybody I've given Dato to has had some stomatitis. Thankfully, it does get better with dose reduction. Prophylactic use of steroids does help, as does salt and soda. The astringents don't, the antiseptics don't. They're kind of stingy, so you want to probably stay away from those. But dose reduction does help. I have a gal who's been on Begonia with Dato and Durva for really, really years and years. And she has a little low grade, depends on what she eats. It's really diet dependent. So it's very managed. She's not losing weight. It's just low grade, but she does take good care of her mouth and everything. So I think it's really quite manageable for patients. I think that, it is going to be patient friendly to give it once every 3 weeks rather than the SASSY day 1 and day 8. But if someone has a history of very dry eyes to start off with, for example, SASSY might be a better option for the patient. It's just going to really depend on patients' comorbidities, et cetera.
Hal, a question we've been asking the last couple of years, what comes first, SASSY or T-DXd and HER2 low, ER positive, triple negative?
So, perfectly fair question. We don't know. I will say a couple things. The first is that I've given a lot of these drugs now, and in the second line, I rarely see magic. I hope some of you have done better than I have, but it is rare to see that like using SG after T-DXd or vice versa gives remarkable responses. I've not encountered it. The second is that neither, and particularly T-DXd, which we studied carefully at Paulo Tarantino at the Dana-Farber's done a lot of work on this, we're not seeing anywhere near the results of the randomized phase 3 studies in terms of time to progression. Probably because in these global studies, they're dealing with a lot of patients who are getting second-line therapy, but they never got adjuvant chemotherapy or things like that. Whereas in the US, the patients who recur with ER-positive or triple-negative disease have almost all had extensive adjuvant chemotherapy already, and so you've really shifted that. So, there are still some great responses, and I think if you look at the collective experience, it's really sobering how bad most of our traditional chemotherapy options were, with median time to progression of like 3 to 5 months. I am not personally seeing, and they've published our data from the Farber and elsewhere, the kinds of 14-month median PFS that are in these trials. My first-line drug, chemotherapy or ADC in ER-positive disease, is almost always capecitabine, and then typically it would be T-DXd. To Ginger's point, the joke is, if you're sitting with your pathologist, you can always find a little bit to make it ultra low, so almost anybody's a candidate for the drug. I'm not sure rationally how to otherwise choose between those two. There's subtle differences in side effects. There's pneumonitis with T-DXd. There's more diarrhea with SG. It's a more frequent visit to the clinic at 2 weeks out of 3 as opposed to every 3 weeks. Those kinds of things affect patient preferences.
Let's finish out with a couple more cases. Joyce, this is an interesting case of a 76-year-old woman. What happened with her, and what did you do?
Oh, she's a patient that I'm going to, I've recommended datopotamab, get her on that next. She basically, it's comorbidities, and she lives far away from the cancer center, but she has an idiopathic sensory neuropathy, indolent bone only, de novo metastatic, and she did well on endocrine therapy for quite a long time. She's got no actionable mutation, and so repeat biopsy, ER positive, PR 0, and HER2 is really 0. Now, I think in our center, they're not really calling ultra low, so I think a lot of these zeros are really ultra low. We don't know it yet, but I have a number of patients that are 0, 0, 0, but they're probably really not 0. They're ultra low, but so she did really well with capecitabine for 18 months, but she could only tolerate 1,000 BID 7 on 7 off because of diarrhea. That was her vulnerable point. She's still basically asymptomatic from the cancer. She's a little fatigued from the treatment, but now she is progressing in her liver, and so I've got choices. I could go datopotamab, I could do sacituzumab, I could do fulvestrant abemaciclib potentially, and I could do a taxane, potentially for this patient. But I think that given all the comorbidities that she has, I think that every 3-weekly datopotamab would be a good choice for her. So that's what we're going to do.
So just out of curiosity, if she didn't have any issues whatsoever with diarrhea, what would you choose? Then I'm going to ask Ginger how she would think it through.
I would go back to fulvestrant abema because I go back to endocrine therapy if somebody's done well. I've had good success with abema post capecitabine, as a matter of fact. So I would go back to fulvestrant abema if she wasn't already if diarrhea wasn't a vulnerability for her.
It's interesting. There have been several of these cases. I don't know. I always think about endocrine therapy and then chemo, ADC, et cetera, where you came back to, whatever, elacestrant, something I would have typically thought about earlier. Maybe sometimes it has to do with when things were approved. Ginger, any thoughts about how you're going to sequence these agents, and even putting aside repeating, the abema or fulvestrant, what's going to come first, dato, saci, or let's just say stick with those two.
Sure. So I too live in one of those great big states in the middle of the country where there's a whole lot of prairie and gophers between me and where my patient lives. And so an every 3-week dosing over back-to-back weeks is going to be something that I think a lot of patients would opt to choose. There's also the side effect profile, which, as we've outlined, dato is quite a well-tolerated drug, different side effects, but usually manageable ones.
I think of Colorado, I think of mountains. I don't think of gophers and prairie.
So the airport's in the middle.
See, everything in
and there's
oncology is a
east.
subset, isn't it? It all depends on which half of the state you're looking at.
Yeah, and there's a lot of mountain passes you have to get over to get to me from those very nice communities. So travel can be a really big issue.
So we'll continue with this group tomorrow morning, bright and early, 7:45. We'll finish up with other parts of breast cancer and then move on to the rest of oncology. Have a great evening. Thank you so much, faculty.
Thank you.